Good afternoon, I'm Dr. Kymberly Watt, and I am a transplant hepatologist at Mayo Clinic, and I'm here with my colleagues.
And I am Samar Ibrahim. I'm one of the pediatric hepatologists at Mayo Clinic.
And I'm Julie Heimbach. I'm a liver transplant surgeon at Mayo Clinic.
And we are here presenting to you on the topic of fatty liver and liver transplantation, what the patient needs to know, its perspectives of adults as well as pediatrics. And we're going to cover the topic of fatty liver for you. So the reason that we chose fatty liver disease to talk about on this webinar is that fatty liver is a very, very common problem in our population. And this is depicted on this slide. And just to kind of update you on the terms we're using here, this NAFLD term is non-alcoholic fatty liver disease, and NASH is a non-alcoholic steatohepatitis. And we will define these a little bit more as we go along for you. But these are very, very common problems. This is a couple of different studies that actually show in a healthy adult population the number of patients or people that are walking around potentially with fatty liver disease. And overall, somewhere between 30 and 46% of the population has fatty liver disease, and about 12% of the population has the version of fatty liver disease that's called steatohepatitis. So this is a very common problem affecting many people.
So as Dr. Watt stated, fatty liver disease is also a public health problem in the pediatric age group, and this is because the prevalence has increased significantly over the last 2 decades. And currently around 10% of our teens are affected. 3% of those have the most severe form called NASH. And as you see in this cartoon, when the liver accumulates fat, we call the condition simple steatosis. It's just fatty infiltration of the liver. But as inflammation develops and injury and scar tissue develop, this condition will be called non-alcoholic steatohepatitis or NASH. As you see, non-alcoholic steatohepatitis and simple steatosis here are both reversible back to normal with intervention. But once the injury is severe enough to cause severe scarring and cirrhosis, this condition becomes irreversible, and it's a predisposing factor for hepatocellular carcinoma or liver cancer.
And actually, although most patients with fatty liver disease do not progress to cirrhosis and need transplant, this epidemic of fatty liver disease does have implications for the field of transplantation. And as you can see depicted here, in the previous decade, our most common indication for liver transplant has been hepatitis C virus, which is a virus that can cause liver injury. In the 2000s, hepatitis C is still the most common reason people require a transplant. But going forward, we do expect that NAFLD will be the main reason that people will be having a liver transplant in the future. It is currently the most rapidly rising indication for liver transplant. And we think in the future, as we get better and better treatments for hepatitis C virus, the main reason that people will have a transplant in the future would be related to fatty liver disease.
So just to step backwards a little bit to make sure everyone's understanding what we're talking about, there are some terms if you were looking through the internet or reading on the internet that you need to identify. So steatosis is a term that is really just referring to simple fat in the liver, and this is what we're talking about when we're talking about non-alcoholic fatty liver disease or NAFLD. Steatohepatitis, though, this is fat with inflammation. So fatty liver disease associated with inflammation or scarring, which is fibrosis. This is NASH. And these are terms that you'll see in the internet. So just to help define that for you. For any medical professionals that are in the audience, there is a differential diagnosis for fatty liver. The most common causes are these top 3, obesity, diabetes, and alcohol, and much, much less common these other causes. So most people don't need to worry too much about this, but medical professionals need to realize there are other causes and they need to look for those and identify those. One of the most important definition here, though, is non-alcoholic. So alcohol can cause fatty liver, and it can cause the fatty liver with inflammation, that's steatohepatitis. And it needs to have non-alcohol as a definition, and this is defined as less than 20 grams of alcohol in a day. The average drink that you would drink, which is a small glass of wine or a bottle or can of beer, or one shot of whiskey, is somewhere between 10 and 12 grams. So roughly 2 drinks a day. These are not the free pour beers out of the kegs, though. This is a bottle. So less than that per day, and this can be a non-alcoholic variety of fatty liver or steatohepatitis. One thing to remember, particularly for medical professionals, but to everyone, is that if you have liver disease and you happen to be obese, or the patient happens to be obese, not every obese patient has just NASH. Now, they may have NASH in combination with another very reasonably common liver disease. There are multiple causes of liver disease out there. Some of the more common ones, if you just look at this study of people going into transplant, alcohol, hepatitis C, and other less common causes of liver disease, such as primary biliary cirrhosis, can also have or can also be obese patients. And so somewhere between 10 and 20% of those patients may also be obese. So the point of this is just simply looking at a patient, or if you are the patient and you are obese, there may be other causes of liver disease that need to be looked for and ruled out so that we know we're only dealing with fatty liver. Important to understand the progression of fatty liver over time, and this is one of the studies that looked at patients over 18 years of follow-up, and people that had just simple fat in their liver had no major consequences as far as chronic liver disease goes. Now, they may very well have other consequences we'll talk about later. The patient that has inflammation, though, of any variety, certainly as it gets worse, they're more likely to develop cirrhosis. So between 20 and 30% of patients with inflammation, that's the NASH part of this, can progress to cirrhosis over about 2 decades. So this is not something that happens in short time. And many people show up to our clinics having just been diagnosed with cirrhosis, and they feel that this happened very quickly. But this has actually been going on for quite a long time, and it can be decades. The problem is nobody necessarily develops symptoms. And so you can show up to a clinic or just get a recent diagnosis of cirrhosis, but this has been going on for some time.
So as it's well known, fatty liver disease is a slowly progressive condition in the vast majority of the patient, but we should be aware that this condition in the pediatric age group might progress in a relatively short time, and general practitioner caring for these patients should be vigilant about follow-up. As we see here, there are histological section over a 3-year interval showing some progression, as shown with darkish bluish discoloration in the second biopsy, meaning that there were more scar tissue on follow-up. So just to educate about that.
So that would involve the minority of patients, but it is a possibility over time, and that is why people need to be followed closely. One of the other important things to remember here is when you look at long-term survival in patients that have fatty liver. Now, this is either just the benign fatty liver that's only diagnosed on an ultrasound, or people that have the actual inflammatory component. This is a combination of these patients. If you follow them longer than that first 6 to 7 years, they actually may experience less likelihood of surviving over that time frame than the general population that does not have fatty liver disease. So this can impact someone's long-term survival. And what do they actually die from is actually more often malignancies or cancer or heart troubles. So just simply having fat in your liver, although when we looked at that previous slide that said having no inflammation didn't have very big consequences for the liver, it may still have consequences for their heart. So the minority of patients ended up having a liver-related cause of death, But this is a very important part of things, that the fatty liver is associated with heart disease, and that heart disease may actually be a bigger problem than the liver disease. But certainly the liver disease is still a big problem in the NASH population.
So what are the risk factors for developing pediatric non-alcoholic fatty liver disease? Age is an important factor. Most of these patients are diagnosed around the puberty. Gender, males are affected twice as often as female, and race. We know that Hispanic are most likely to be affected compared to Native American, then white and Black are least likely to be affected. Other components of the metabolic syndrome are risk factor, and the metabolic syndrome is an association of manifestation associated with obesity, including high blood pressure, abdominal obesity, high blood lipid, and insulin resistance that predispose to diabetes. So these conditions come hand in hand with fatty liver disease. And here I list abdominal obesity, high triglyceride, and insulin resistance. Genetic predisposition, several genes have been described to be associated with non-alcoholic fatty liver disease. Here we are listing one of them, but at the end we have to acknowledge that the gene predisposed and the environment disposed, and a diet rich in high fat and high carbohydrate content, in addition to a sedentary lifestyle, are the major risk factors.
Many of these risk factors also exist in the adult population with a dominance of that metabolic syndrome. So obesity, diabetes, high cholesterol, high blood pressure, those are all risk factors in the adult population as well. So how do these patients present? Generally speaking, most people have no symptoms at all related to this, and they will just simply have some abnormal liver tests on blood work, or they'll have an abnormal ultrasound picture or a CT scan picture that detects the fat in the liver. Sometimes people may show up with an enlarged liver, that's something called hepatomegaly, but up to 50%. These are only generally published studies, so it's probably not as common as 50%. Some people may have advanced disease, and those are the people with scarring in their liver to the degree of cirrhosis, and they may actually show up for the first time with jaundice, that's where your eyes or your skin turn yellow, swelling, that can affect your swelling in the legs, there can be swelling within your abdomen, and then signs of something called portal hypertension. This is a term you might see on the internet, and this is a consequence of cirrhosis. And that's something that can show up with GI, with gastrointestinal bleeding or something like that. An important part to remember as people develop more advanced liver disease or cirrhosis, they get very sick and their muscles can start to waste. And if you're obese or your patient is obese, this muscle wasting isn't as obvious, even particularly if patients have a lot of swelling, especially in the lower extremities or your lower legs. So muscle wasting is a very important part that can occur, but can be very hard to detect in some patients. Lab features, so if your doctor is checking your blood tests, usually you'll see abnormal liver enzymes, but frequently people can have completely normal liver enzymes. Usually, unless you have advanced liver disease, the liver function tests, these are proteins your liver makes, such as albumin, bilirubin, INR is a blood clotting test. Those will all be normal unless you have very advanced disease. There can be inflammatory markers that are elevated, and this ferritin blood test is usually a sign or a test looking at iron, but it can also go up in inflammation. So it's up quite frequently in fatty liver disease. Certainly, if your risk factors to get a fatty liver include high cholesterol or lipids, or high glucose or diabetes, those things will be elevated on your blood tests as well. Less commonly, you can see an antibody in your bloodstream. It's called ANA, and this can be very mildly elevated, and it's still associated with fatty liver and not necessarily an autoimmune process. And some people can have some elevated iron saturation. So this can make it difficult to interpret, and sometimes these types of tests being abnormal is more of a reason that you might need a liver biopsy. An important thing to know, though, is that you can still have inflammation in the liver, and you can still have scarring in your liver despite having normal liver enzymes, and that makes this a challenge to the medical provider.
So how we diagnose non-alcoholic fatty liver disease in children? As an adult, most children are asymptomatic. On physical examination, we might pick up on some signs like obesity, especially abdominal obesity, enlarged liver, or acanthosis nigricans, which is a blackish discoloration of the skin, mainly on the back of the neck or in the armpit. Nowadays, the American Academy of Pediatrics is recommending to screen kids who are overweight or obese twice a year after the age of 10 to diagnose this condition early and initiate an intervention. The definitive diagnosis requires a liver biopsy, and the liver biopsy is done in patients who have persistent elevation of liver enzyme in spite of lifestyle intervention. And this is done to distinguish simple steatosis from the more advanced stage of the disease, NASH, and exclude other causes of liver disease that might mimic NASH.
So how patients often show up to the liver clinic having this question of fatty liver disease is sometimes they've just had an ultrasound or a CT scan showing this. If there is a concern by the medical professional for liver disease, they can order an ultrasound or a CT scan, and this can help determine if there is fat in the liver. It is not a perfect test, so that means it lacks some sensitivity. So if there is less than a third of the liver cells affected or less than a third of the liver affected, it may not necessarily pick up smaller amounts of fat in the liver. So you cannot rule out a fatty liver on a normal ultrasound or a normal CT scan, but if you see fat in the liver, it is there. So it is a component of what's going on in their liver if you see fat in the liver. And this is just one example for the medical professional out there, is if this liver looks a lot darker than that spleen, it's likely that they have fatty infiltration in that liver. So imaging can help. Imaging with ultrasound or CT scan can certainly help diagnose the fatty infiltration. There are some tests that can be done in order to help avoid a liver biopsy, and this may not be available in every institution, but there are certain types of tests. If you're really just going to do a biopsy to find out how much scarring there is in the liver, then this thing called a fibroscan is a little pulse wave that can tell you how stiff a liver is. It's not as effective in obese patients, and so it can be, obesity can affect its accuracy. There's a special type of MRI in a small number of institutions currently, but is probably going to be expanding, that can show how stiff a liver is with looking at the whole picture of a liver. And these are new tests that are available simply to answer whether there's scarring in the liver. Sometimes you'll still need a liver biopsy to rule out other causes of liver disease or to help make the diagnosis. And sometimes you will need a liver biopsy to actually find out how much scarring there is in the liver. But these may be some options in some places. So how do we manage this fatty liver?
So intensive lifestyle intervention is our first option or first recommended intervention. Medical therapy, and at the end, bariatric surgery is kind of the last resort for patients who are not improving on the above options. So first, diet, increasing fruit and vegetable is key, eating healthy portion and not skipping breakfast, avoiding sweetened beverage as those are rich in high fructose corn syrup, and reducing takeout and fast food meals, trying to cook in-house. Also, activity is important, increasing aerobic physical activity and reducing screen time, and this include video games, internet time, and also TV. We have to prevent other hepatotoxic agents, and by this, I mean drugs or herbal supplement. We recommend, again, the usage of weight loss medication because there has been report of drug-induced liver injury from these agents. And we recommend that all our patients be vaccinated for hepatitis A and hepatitis B to prevent an acquisition of a viral hepatitis that might potentiate the liver injury in patients with fatty liver. Also, we recommend our adolescents, again, the usage of alcohol
And these same approach applies to the adult population as well. And generally speaking, we would recommend a goal of a 10% of baseline weight reduction at roughly a rate of 1 pound to 2 pounds per week. And this is helpful because it'll help to get the fat out of the liver. It also helps improve the metabolic syndrome. So your diabetes, the high blood pressure, cholesterols all improve with weight loss. And exercise is actually a really important component of this because that helps to improve that insulin resistance so that it improves your insulin sensitivity overall. But just the exercise alone can also help get that fat out of the liver. And this is a study that I can quote here where you can see that the aerobic or resistance exercises actually reduce the liver fat content within the liver biopsy in these patients by about 10%. So exercise and diet can help reduce the fat in the liver. And if you're able to reduce that BMI, this is a body mass index. It's a calculation of your weight over your height. And if you can reduce that overall, you can improve your liver tests, improve, the metabolic syndrome parameters improve, and actually the scarring and the inflammation in the liver, if there's not advanced scarring, may also improve. And there are actually a few different studies that have shown that. So weight loss is the key, and that's by diet and exercise. You also need to optimize that metabolic syndrome. So again, that's diabetes. You would treat that as you normally would. High blood pressure, you might want to consider certain types of blood pressure medicines. These are specific types of medicines that might help with scarring in the liver and reducing that overall scarring. If you have high triglyceride levels, now that's a special type of a lipid or cholesterol that your physician will follow. Fish oil may actually help that. There are some studies in humans coming out on that too, but so far it looks like it may help that. We don't have a lot of data on that. Trying to take diabetic medicines that are the oral pill versions as opposed to insulin may be of benefit as well. And then there are some studies out there that suggest vitamin E may be of benefit, but it is a mild benefit. And there are other studies in other populations that have shown that there are some risks to that. So that's something I would suggest you discuss with your medical provider.
So the medical treatment in pediatric is not that much different. Currently, we don't have a proven medical therapy that cure this disease besides weight loss and lifestyle intervention. So vitamin E is one of the medication that has been well studied in the pediatric age group, and the dose that was studied is 800 international units per day, and it offers histological benefit in children with biopsy-proven NASH, but the liver enzymes in the blood did not change much. I have to add here fish oil because we all know the health benefit of fish oil. It may provide modest benefit, especially in patients with associated high blood triglyceride level.
So one important component of this is often people are treated for their high cholesterol with a statin medication, and many people will be familiar with that. And there are some risks to people's liver when they take a statin medicine, and that's why they have to have their liver tests monitored, but the risk is really quite low. And there's always a question of whether somebody with chronic liver disease, and particularly somebody with fatty liver disease, whether they can continue their statin medicine or whether they can start one. And there are actually several studies out there, this is only one of them, several studies that can prove that this is something that can be continued or even started in chronic liver disease and fatty liver disease, and you would simply follow liver enzymes while on it. And in fact, what this study even shows is that you might actually get a benefit in fatty liver. Now, most of the studies that were done looking specifically at these drugs as a treatment for fatty liver did not find a big benefit, but it certainly is safe and may provide some degree of benefit. As you can see, the placebo group had higher liver enzyme tests in this particular study. So if the question comes up, for the most part, you do need to be monitored on a statin medicine, but it should be safe to be able to continue on those medicines. There are some newer studies coming up that if you're reading through the internet, you might come across, and some of these look at caffeine in regular coffee, and that can be associated with reduced scarring in the liver, so reduced fibrosis. There are a few very small studies looking at this, and it is something that's getting a lot more attention. So this may be something that at least is something you don't have to stop. Probiotics, now that's become very popular in a lot of different diseases. Probiotics and prebiotics. So prebiotics are things like fiber. There's very small studies that these might improve liver enzymes. Certainly this is going to get a lot more attention in the coming years, but there's no recommendation that anyone can truly make on probiotics with respect to NASH at this particular moment. There's another agent out there. It's specifically looking at a bile acid receptor. This study was stopped early because it hit an endpoint that was an important endpoint that looked like it might be effective. So this is something that your physician may or medical provider may discuss with you. They are not FDA approved and not mainstream, so we won't discuss this in any more detail. So if weight loss is an important part of treating this problem, what about bariatric surgery? And there's a few patients that would benefit from bariatric surgery, but I think the important thing to remember is people with advanced liver disease or cirrhosis or advanced scarring should probably have a very long discussion with their liver doctor and their bariatric surgeon before going on to have bariatric surgery. It's not a completely contraindicated discussion, but it is something to make sure it isn't taken too lightly. So patients that don't have cirrhosis, bariatric surgery may be an option for them to help with the weight loss.
So as Dr. Watt mentioned, the essential component of treating obesity-related liver disease or fatty liver disease is reducing the weight. And certainly the safest approach in someone that already has liver disease would be to continue to do that with a non-invasive approach. If the non-invasive approach has failed, we've exhausted all of the options with regard to losing weight, then weight loss, by a surgical method could be considered, but it really has to be in the context of not having another good option. For someone that has the benign fatty liver disease without any cirrhosis, this is generally a relatively safe operation, but it's a surgery. And certainly if we can do this without surgery, that would be great. The problem is that not everybody has a good result with attempts at weight loss. So if we're going to proceed with surgery, we can see that patients who've had surgery and had fat in their liver after they've had the surgery have significant improvement. The fat goes away if they lose weight with surgery. This has been shown with the gastric band. The gastric band is shown right here in this picture, which basically is a silastic band that restricts the amount of food that can fit in the stomach. So patients feel very full very quickly, and that's the effect of this. There's another surgery called the Roux-en-Y gastric bypass, which can be done either with an open or a laparoscopic approach, and the laparoscopic approach is the more common approach at the current time. That is shown in the picture up here. The Roux-en-Y gastric bypass restricts the amount of food a patient can eat, so the stomach changes from this large area to this very small area. In addition to restricting the amount a patient can eat, it also leads to malabsorption because there's a part of the intestine that you can see right here that normally would have seen food, but with this bypass, the food doesn't go to that part, it just bypasses right by it. So we cause malabsorption with this operation. So it works in two ways, and this operation is really the gold standard because it's the most effective at achieving weight loss. And with that operation, we saw even improvement in fibrosis. So patients that even had the scarring form, that can improve. Other studies have shown improvement in steatosis, but not the similar improvement with inflammation or fibrosis. We don't exactly know where the tipping point is, where we can still improve, or whether we've gone over to the point where we can't improve. A newer surgery is shown down here. This is called a gastric sleeve, and this actually divides the stomach. And is just a restrictive with no malabsorptive component, but it seems to be just as effective as the Roux-en-Y gastric bypass, at least in the early studies, at controlling some of the components of the metabolic syndrome as well as achieving weight loss. So these are all options that can be considered for the appropriate patient, not for the patient with advanced liver disease.
So the important part to remember about bariatric surgery is if somebody has significant rapid weight loss, they may actually get worse liver function. So you have to be followed very, very closely if you have an underlying liver disease specifically.
So bariatric surgery in adolescent. Actually, bariatric surgery is an option in adolescent with severe NASH and a BMI more than 35. These candidates should be screened carefully for psychological readiness and for skeletal maturity. Here I show one of the study done in adolescents who were randomized either to have the bariatric surgery, which is gastric bending, and those patients are represented in black dots and black line, is the weight loss over the period of the study, which is 2 years, and patients who have been randomized to just lifestyle intervention. And as you see here, patients who had the bariatric surgery had more significant weight loss compared to patients who had only lifestyle intervention, though some patients with lifestyle intervention did lose significant amount of weight. So this is to say that this surgery is possible in adolescent and it's effective. And it's associated with improved lifestyle and metabolic syndrome.
So overall, an approach to how to manage this fatty liver disease or steatohepatitis is a trial of 6 months of weight loss. So generally, we would say low calorie, low fat, although a low fat diet isn't the specific recommendation, low calorie, exercise. And if the liver enzymes seem to be improving, then just continuing with those weight loss efforts and observe again in another 6 months. If the enzymes are actually rising, well, then that patient probably needs a liver biopsy. If enzymes are staying the same and there has been weight loss, that might actually be another reason to do a liver biopsy as well. So I think a trial of 6 months of weight loss and see if things improve may actually avoid liver biopsies. Certainly treating diabetes with the oral pill versions of diabetic medicines rather than insulin is preferred. Treating the high lipids with statins or the other medications, including fish oil, is appropriate. Treating the high blood pressure with certain types of blood pressure medicines would be a discussion with the medical provider. And then considering bariatric surgery if all attempts at weight loss have failed over the years and the BMI is over 35. Now, if somebody has end-stage liver disease or has cirrhosis with elements that the liver is not functioning properly, that's when you go for a liver transplant referral. And so now the next part of this is just talking a little bit about liver transplantation.
And as we mentioned earlier, liver transplant for fatty liver disease is rapidly rising. And in fact, it's now the third most common indication for liver transplantation. Patients with NASH, the inflammatory form of the fatty liver disease, are also at risk for developing liver cancer. Liver cancer can actually be treated with liver transplant if the cancer is very limited in stage. It's very early, then it can be successfully treated with transplant. How do patients with obesity do if they undergo a liver transplant? Well, that has been looked at very closely. And initially, we thought they didn't do as well. This is a study that demonstrates that patients that have a BMI, or that body mass index, from normal up to very heavy, which is a BMI of 40, were doing equally well. But those who were heavier than that, so a BMI that was over 40, or who were very light, a BMI under 18.5, did worse following the transplant, in the years following the transplant. But this study was limited by the fact that there weren't that many patients in these really heavy or really light groups. And then additionally, they didn't actually correct for the fact that some of these very heavy patients had a lot of fluid in their abdomen. That fluid, called ascites, actually increased their weight, and they weren't actually necessarily as heavy as that. They had this special problem with ascites fluid. So the more recent studies correcting for those various factors and looking just at a more recent cohort demonstrated still that those really undernourished or malnourished people are still doing worse, but the other patients, regardless of their weight, are able to be successfully transplanted. But it's really important to recognize that these are just very carefully selected patients where we checked to make sure their heart was strong enough and other parts of their body were strong enough to undergo a transplant. So it's not every patient who has got advanced liver disease and who is heavy would do well. We have to be sure that the other parts of the patient would be strong enough to withstand a transplant. In terms of what happened to the patients, well, in general, whether they may have survived the surgery successfully, but we did see that patients tended to stay in the intensive care unit longer, have a longer hospital stay, and be prone to having more infections if they were heavy. although again, the survival in this large study was similar for patients who were heavy. So to summarize, if you have to have a liver transplant and you're heavy, we see that this is becoming increasingly common. And we see that in the short and long term, we may have more trouble in terms of complications, but we can have an overall acceptable outcome if we select the patients carefully. Although one of our big worries is the same problem that's going to come back again after transplant. So patients would be at risk for getting NASH once again following the transplant if we don't address the underlying problem, which would be the obesity. And certainly that obesity can lead to other problems, not just with the newly transplanted liver, but with problems like diabetes, heart disease, and cancer, as well as kidney disease. All of these things are actually affected by the anti-rejection medicines that a patient needs to take after a liver transplant. So we really worry about the cumulative effect of the anti-rejection medicines with the extra weight.
So in summary, last slide for everyone. In summary, so the NAFLD, NASH, both fatty liver components is very common in the general population. It affects adults and children. It impacts long-term survival. Weight loss and lifestyle are the key to managing this problem. And liver transplant is feasible with good results, but coexisting diseases may actually limit candidacy for transplant or can be very problematic after transplant. And so with that, we'll leave time for questions. So I'll read out some of the questions that are coming in. What's the most common cause of fatty liver disease amongst children, and how can parents best manage this?
So as we said, increased body weight is the most common cause. Best management is a lifestyle intervention. All the family should be committed to that, reducing caloric intake and increasing physical activity. Those are the mainstay.
Okay. The next question is, please discuss a prognosis of somebody who has cirrhosis, stage 4 with hepatic encephalopathy. And so, prognosis is very hard to actually answer that question. People with cirrhosis, encephalopathy is one of the elements of decompensation. So this is telling us that the liver is not functioning as well. Sometimes people can have the blood flow bypassing the liver through something called a shunt, and that can worsen encephalopathy without necessarily having worse liver function. So once somebody develops any element of decompensation, whether it's encephalopathy or fluid overload like ascites or edema, which is swelling in the legs, or if they've become more jaundice, muscle wasting, those sorts of things tell you it's time to look towards a liver transplant. Once somebody has one element of decompensation, about 30% can have just worsening progressive liver failure. Other people, if it's not an element of the liver not functioning, it's hard to give an actual prognosis. So that would generally give you an indication you should be looking towards a liver transplant evaluation.
So the next question is that I was diagnosed with NASH in 2011. The doctor instructed me to take vitamin E and C. In addition, he told me to exercise 150 minutes a week. Is there anything else I can do to prevent it from turning into cirrhosis?
So the biggest answer to that is the weight loss. And that is the only real answer that we can say with any definitive certainty, is that the weight loss needs to happen. And the exercise is a means to that, but the diet is also very important. And so that would be the key element. You probably don't need to stop drinking coffee. That might be beneficial, but I'm not sure it's going to cure any problems. But the weight loss really is the key. So the next question is, why are oral diabetes medications better than insulin? Well, insulin is actually an anabolic hormone. So people can actually put on weight on insulin. And so many of the oral diabetics don't have the weight gain. Now, some of them actually do. Some of the oral diabetic medications hit certain receptors that can actually be beneficial to the inflammation within the liver. And that would be a reason to pursue the oral agents more over the insulin.
So the next question is, do fatty liver disease and PBC relate to one another?
They do not. Those are two very separate diseases. They may coexist in the same patient, but they are not related in any specific way.
The next question is, I have PBC and PSC. My MELD is 10, but I also have hepatic encephalopathy. Why do I have to get worse before a transplant? And why can't I get a partial liver from a living donor? So this is an excellent question. And it relates to the fact that there was an observation that patients with a certain MELD score, we could identify being about between 12 and 15, actually had a higher risk of death immediately following transplant than if they stayed on the wait list. So many centers have used that number as a guideline to say, well, really, you need to be a little bit more sick before we can accept that risk of liver transplant. However, we do recognize that there are some patients who are really suffering from a lot of the complications of liver disease, and they may benefit from an earlier transplant. So we and many other centers take it as a case-by-case approach, and certainly you should be talking to your transplant center about transplant if your symptoms cannot be controlled, and that would probably be independent of your MELD score. And if your transplant center doesn't offer living donor transplant, you need to ask to be referred to a center that does offer living donor transplant.
So the next question is, my wife was diagnosed with PBC and autoimmune hepatitis. In the liver biopsy, there was no fibrosis. It could be possible for her, is it possible for her to have a liver transplant? And the answer to that is actually, that's really good news in some ways, to have that diagnosis with no fibrosis. So if she has autoimmune hepatitis, is a treatable form of liver disease, and generally, if well controlled, you may be able to delay, at minimum delay, if not stop any further progression. PBC is also a disease that has a treatment. Now, it is not a cure for the disease, but treating that disease can also delay progression for many years. And if she currently has no scarring, so no fibrosis means no scarring, it can be a very, very long time before PBC ever, if it ever progresses. And it may not if it responds to the treatment. So those are two diseases that can have treatment options, and she certainly does not need a liver transplant at this particular point and may not ever need a liver transplant if it's controlled.
The next question is very challenging, and that is, are there specific foods, or what are the best foods to eat? And this question is challenging because there's a lot of data on this, but none of it is particularly solid. We do know that foods that are very calorie dense are ones that we would be concerned about. Foods that have a high glycemic load seem to potentially be worse. Foods that have that are both high in cholesterol and high in fat, such as fast food, we think are potentially worse. But overall, the bottom line is, for patients who are obese with fatty liver disease, the number one intervention is reducing the weight, and whatever means, in terms of calorie restriction that can be achieved to do this, is probably, the way to go. So it's sort of a, reducing the portions, reducing the calories, and increasing the exercise. It's a fairly simplistic way to look at it, but it's what we know can work.
There really is no one food that is causing the problem other than high sugars and overall high calories. So if there's one food to avoid, I would probably say it's the simple sugars. Certainly things with high fructose corn syrup would be definitely things to avoid, and that's more in the effort for weight loss, metabolic syndrome control, but it may also be part of the instigator for the insulin resistance, which drives some of this steatohepatitis. So simple sugars, I would say to stay away from. Other than that, there isn't a specific food group that you would follow. And the fad diets, things like eating only protein, and those things are very, very hard to maintain. And although they can lose weight in the short term, it is not sustained weight loss over the long term because they're very, very hard to maintain in the long term. So I think a simple calorie reduced, get all the food groups in, and go with that as far as the weight loss goes. There's another question here on input regarding resveratrol in NASH. And, basically for there are no drugs right now that we can say are helpful in NASH. So there really isn't any input for any drugs that we're going to be able to discuss other than what we've already outlined here. So there's no magic pill for NASH right yet. Some of the obesity medications or weight loss medications haven't had a lot of studies specific to NASH, and so a lot more data is needed before those types of medicines can be recommended.
The next question is that I am not overweight and I have been diagnosed with early stages of fatty liver disease. What can I do to help reduce the inflammation of fat into the liver? I have 4 relatives, including my mother, who's been diagnosed with NASH. Could it be genetic? I went for testing to be a live donor for my mother, and that is how they found it.
And this is a very challenging group of patients. So this does happen. It is not always that everybody with NASH is obese. If you're not obese, commonly diabetes is a main problem. Insulin resistance is sort of the lesser version of diabetes, and it is the main feature. The liver is what processes fats and lipids, and so it may vary, and there certainly are genetic risk factors and genetic associations. Whether it's all just genes, we don't know. So there's definitely a lot more that we need to know about this particular group of patients, and it's not as common to have NASH without obesity, but it certainly is something we see quite frequently. So there likely is a genetic component to this. There may be an environmental component to this. There may be a lipid metabolism part of this, but we don't have a specific answer for why those people that are thin that have fatty liver. We've had people that can run marathons and still have fatty liver. So there's a metabolic part of this that isn't well defined in that group of patients. So controlling insulin resistance, even the smallest amount of weight loss can be helpful. Controlling lipids are the mainstays. Whether you take an antioxidant or something like vitamin E, it may be beneficial in that particular circumstance, and fish oil, that kind of stuff. But there's no data around that. So it's a much smaller group of patients to be able to answer that definitively.
And regular exercise may be a benefit, even if you're a normal body weight individual. If you're very sedentary, adding regular exercise potentially could be a benefit. So what is the rate of recurrence of fatty liver disease after transplant? This is a great question. It's something we certainly worry about, and we do see fat coming into the new liver. The good thing is we don't see a rapid progression to advanced cirrhosis and inflammation, but we do see the fat coming back. And over time, we are concerned that it can cause injury, but certainly in the first 5 years, progression to advanced cirrhosis is rare. But having a weight reduction either before, during, or after the transplant would be certainly beneficial in preventing the recurrence of fatty liver disease following transplant.
The prevalence numbers that are quoted in the literature is about 40% of patients will get fat back in the liver. Whether it's associated with inflammation is hard to determine. Most of the studies don't have biopsies that are done on a protocol basis, so somewhere around 15% is kind of the quoted number right now, but it's likely underestimating. So the key to this is there's always weight gain after a transplant, and to avoid that weight gain is probably the key to avoiding and managing the recurrence of NASH or NAFLD in the liver. So next question is, I suffer from depression and anxiety, and I have to be on a medication the rest of my life. Will this type of medication make my NASH worse? Well, that's a tough question, not knowing what the medications are. There's no specific link to the depression drugs themselves and NASH, other than many of them can cause weight gain. So choosing one that doesn't cause weight gain would probably be an important part of this. Some of the treatment for even depression and anxiety, you may actually get better with the exercise that's recommended for your NASH as well. So the medications themselves, depending on, which one they've prescribed for you, wouldn't specifically affect NASH. Now, any medication can cause, drug-induced effects to the liver. So it is something that I would probably recommend your doctors follow your liver tests while on any new medication. So that would answer that question. Is there one more there? No. Okay. I've always had a very low lipid profile, but was diagnosed with NASH and cirrhosis last year. Is there a connection, or do you see many patients like this? So, the lipids are one component of this, and certainly people that have high lipids are at higher risk, but people that have low lipids can have any of the other risk factors for fatty liver. So it is not uncommon that we see people with fatty liver that have normal lipid profiles. We see people with fatty liver that aren't particularly obese, and we see fatty liver in people that don't have diabetes. Those risk factors make it more likely, and certainly more likely to have NASH as opposed to NAFLD, but you can definitely get this without any one of those specific abnormalities. Sorry, she's typing right now. We'll take a second here.
So the most common contraindications to performing a transplant are really the diseases that cannot be improved or basically fixed with the transplant. So if patients have advanced heart disease, this would be a main reason that we wouldn't be able to go through a transplant. The transplant is a very stressful operation on the body, so the patient needs to be strong enough to withstand that stress. So issues with the heart and lungs would be some of the more common reasons that we can't go to transplant. If patients have a cancer that may have recently been diagnosed and is either still undergoing treatment or has a high risk that it could recur in a short interval, this would be another common reason that a patient would not be eligible to have a transplant. If their overall their liver disease is too advanced and they're too weak to withstand the surgery, this would be a reason that we wouldn't be able to safely consider transplant. Each case would have to be considered individually, but those would be some of the main reasons.
Well, we're going to sign off now. We'd like to thank all of the questions, and thanks everyone for their attention, provided that's been happening. So thank you very much.
Thank you very much.